All right, let's get going. Welcome to the masterclass. I'm going to hand over to Team Awesome, Terry and Rachel. Please give Terry and Rachel a warm welcome.
Thank you. Thank you for being here. Now, I must explain, you saw we had a little bit of a moving around there. Apparently, the cameraman said, "This is my better side." Both sides are perfect, thank you, Paul. But yeah, apparently this is my better side. So we just had a little reorganization. Today, I feel is a huge privilege, firstly for me, but I think for all of us, that we have an ostomist called Rachel who's prepared to work with us in this way, who's prepared and brave enough to, in public, allow us to observe her abdomen, to do a pouch change, to see the complexity of the stomal situation that she manages on a daily basis. I think it takes a lot of courage, and I think we're very privileged that she's allowing us to share this with her. So, Rachel.
Hello.
Do you want to perch on the side? We're not going to have a little perch to start off with. Because the masterclass is entitled Complex Stomas. But actually, this is about learning from an individual called Rachel, who has, on a daily basis, a complex stomal situation that she deals with. She's not a complex stoma. She's an individual, and we need to learn and understand what life is like for Rachel so that we can understand what the best solution is to offer for her. So, Rachel, what matters to you?
That's a really good question, and I really love that question because for me, having my illness, I lost my independence for a really long time. So for me, what matters to me now is independence, to be able to have a level of independence in my care or in where I live and what I do. I also have a blog called Rockin' Two Stomas, and because I have a urostomy and an ileostomy, I like raising urostomy awareness, having friends, and just enjoying life, not letting my two stomas stop me from doing anything, because it did for so long. I felt isolated, alone, I was a victim, and I didn't know how to move forward. And slowly things have come, and I've just embraced each one, and now I'm here today in front of everybody.
But also, you do have a medical insight, because actually, what's your profession?
So I was a therapy radiographer, so I was band 5 therapy radiographer, and I was in university and I was training. I was in my third year of university, and I ate chicken, got Campylobacter, and that's when my disease started. So I managed to get a 2-1, and then I started working in Bristol Oncology, and then my bladder and bowel just started failing. So it was down to that, but I loved my job, and that's why it's lovely being amongst all you nurses and healthcare professionals, because I used to do this, and I never thought I would get back, and now I'm in a different capacity. So it's really great.
Okay, so you might have a complex clinical situation, but actually you're a quirky individual.
Yeah. I like that, quirky.
You're a quirky individual. You've got your own style, you blog, you do video blogs, YouTube. You know, you're a quirky individual.
Thank you, Terry.
I don't mean that in a nice way.
No, I like that.
But you do have a complicated medical history.
Yeah.
So it all started with chicken. We're not going to go too much on the downer on the chicken, but actually that caused autonomic neuropathy. So it caused failure of your gut and your bladder. Mm-hmm. Now, Rachel's urostomy is obviously an extremely important part of her, but for the time constraints of today, we're not going to be interacting in any way or changing the pouch of Rachel's urostomy. We're actually going to be focusing on the ileostomy that Rachel had formed in 2012. Okay, but having two stomas is a big thing.
Yeah, and because when I had my urostomy in 2015, and I had catheters for 7 years. I had suprapubic catheter for 7 years after self-catheterizing, and then the cells, I had a routine cystoscopy, and the cells mutated, and I had to have the bladder removed within 2 weeks, and lymph nodes removed, and I had a stoma. And I was looking in the mirror, and I thought, I didn't like the one I had, and it was prolapsed and complicated, and I thought, how am I going to cope with 2? And then when I actually had it, and after 3 months in stay because of complications, I got home and I thought, oh my gosh, life is so much better, and I just grabbed it and I've just gone with it. But for years I thought I was the only one with 2 stomas because it wasn't talked about, and being a younger person with a urostomy isn't talked about. So I then started my blog to help other people where I felt so alone, not feel so alone. And I had quite a lot of interest back, where now I've started a group on Facebook with other double baggers, as we're called, together, and it's, that's...
But it really resonates with me earlier with Steve, but now with Rachel. The talk we had this morning about homeland and the new stomaland, and this feeling of isolation and loneliness and depression, all the things that Rachel experienced, and she had obviously a very proactive way of dealing with that, because she reached out via digital communications, via her blog, social media, to actually reach out and find other people. But not everybody is able to proactively reach out, but just to know that actually there are Facebook pages, there are support groups, there are supportive information and people with 2 stomas, so that if you have patients within your practice that have two stomas, that there are resources out there to support them and help them on their journey to their new stomaland. Okay, so you came, as we heard yesterday, I was trying to be kind of proper, and as if Rachel had consulted her stoma care nurse with the problem, but actually she stole some of Steve's products, okay? So I can't really, try and go with this story, but what were the reasons that you wanted to try Steve's concave pouch when you saw it?
So I saw how it changed Steve's confidence in his life, because he very much before, even though when we weren't going out, we were still friends from the YouTube show, and I saw how he had a lot of leaks and had to take supplies. When he tried it, it's like his face lit up. It was like he found a product that worked, and I thought, oh, I want a bit of that. I've got a hernia, I've got a prolapse, And I kept going, come on, Steve, give me one. I'm not allowed, come on. And so I managed to get one, and then the rest is history, because then Steve mentioned it when he...
So much for that confidentiality for me, signed.
We were really good, we kept it between us, but when I saw... I have to add that in. But I saw how it changed him, and because I knew, so I've got quite a large prolapse that isn't so large today, but fingers crossed we can get it in. But I use, before I used the Coloplast Mio Convex, which with a prolapse isn't advised, but when you have a prolapse, the flat bags just fall off with the weight. So I had to use a convex, and I knew it was making my prolapse worse. So I never, even though it was brilliant, and I left it on 5 days, so you're sorry at me, but it was brilliant, it worked for me. I knew it wasn't great for a prolapse because it'd make it worse. So that's another reason why I wanted to try it.
But also, Rachel's stoma, as you will see, prolapses, but it's a telescoping prolapse. So there are times when actually it reduces significantly. And you will have seen outside that there's a selection tool that helps you to decide what, for the body shape, which would be the most recommended product. And we would say, in theory, that we're advising that if you have an outward body shape, but you have liquid output, and you have a stoma that is flush with the skin, we would recommend convexity. And that's the recommendation, but This is Rachel, the individual patient. So for Rachel, the problems with the change in size with her hernia, but also the expanding movement of her stoma, meant that a convex product was not as secure as she needed it to be. So you'll see during this pouch change that actually we use a seal, which just allows that if the stoma does go flush at night, maybe if she's lying flat, she's not going to get any leakage underneath. But if you look at the selection tool, this would not be on paper what we would be recommending. But actually, you'll hear from Rachel how it's resolved some issues for her. So again, this is the importance of looking at the individual person rather than what's written on a piece of paper about a stoma. What's best for Rachel and her stoma. So it's really about having the confidence to try something for an individual that maybe the bit of paper says, don't do that. So realistically, you were having lots of leakages.
Yeah, I was having, it was more the channeling and the creasing. So I was trying to crease it out, and I loved the convex, but I found that there was lots of creases. So I would use the base plate extenders to help. But yeah, that's why I wanted to try it as well, because I was having leakage. Because at night, my stoma is prolapsed all the time. As soon as I stand up, it's gone. With all my refashion surgeries have failed, so I'm used to it now. But at night, it goes right in and it's flush to the skin. So that change is quite difficult sometimes to find a pouch that fits.
That can accommodate that.
Yeah.
And just to explain that Rachel has had multiple repair surgeries, so revisions of the stoma for the prolapse, but an underlying connective tissue disorder means that actually the prolapses are recurring. So there's no surgical method at the moment to actually resolve this for her. So there isn't a surgical option. She said, was it 7 or 8?
I've had 8, and I had them in a year and a half, so it was really, and it was full abdominal, it was tough. But now my surgeon said to me, I'm not touching you anymore, you're so complicated. I get every complication afterwards. And he said that he won't touch me. And I just hugged him and I went, thank you for making the decision. Because I was on this roller coaster of failure. Then I was like, then it would fail, then I'd have surgery, then it would fail. And I couldn't move on from it. And now, yeah, I've got a big prolapse. And like, it's a bit troublesome, but I can lie down, put ice on, I have my own routine to get it in, and I live with it. But having a prolapse, because there aren't so many people out there, it makes you feel it's not very nice, you know, and with all those issues.
Okay, so what we're going to do today, so Rachel is going to lie flat. We're going to remove the pouch and see the extent of the prolapse. We're then going to use Rachel's technique with ice to reduce the prolapse and to put it back. And then we're going to put a new pouch on. Now, Rachel, unlike Steve, our previous participant, does this procedure lying down for obvious reasons. Now, certainly in hospital, potentially you'd be more used to using sugar, sprinkling sugar on a prolapse, but actually for Rachel, ice in a cloth is the way that works for her. But in hospital, I'm sure you would sprinkle sugar, withdraws the water, reduces the prolapse, and allows you to reduce it. Okay, but this is what works for Rachel and works for many other patients at home. This is what people do at home.
With the sugar, I found it really hard to get because I haven't tried. Terry told me to cut a hole out and try that way, and I might try that. But ice is easier because I found I couldn't putting on a new base plate. It didn't stick well because of the sugar. So I found that ice is easier to use, and you put it on top, and it can reduce it.
Yeah, and so again, you know, in our literature, you'll see sugar is the way to go, but yes, it acknowledges we can use ice, but actually for many ostomists managing this on a daily basis, ice is easier for them to use at home. So again, just to be mindful of that. Okay, Rachel.
Cool. I'll put that over there.
Now I'll get the.
Actually, I might stand up.
Take your time, Rachel. You're the boss.
Thank you.
So, how do you like to position these pads?
I just don't want it to go on my trousers.
No, and neither do I. No,
Okay.
that wouldn't be very slick of me. So I'm going to just do more than you probably would, because I don't have your expertise with this. Okay, so I'm just going to get gloves. Now, Rachel, do you use gloves at home? No, the real answer, not the...
I should, but yeah, sometimes I do. But I like to use it because I have to push it back in, and my stomists in Bournemouth taught me how to do that.
Okay.
So I prefer.
Yep, that's
use
fine.
them.
No, that you use. I want you to have what you normally have at home to show us how you manage this.
My hernia is quite a small one, really, compared to others.
Well, and also you're lying down now. So as we
Yeah.
saw with Steve earlier, she's lying down, so the hernia is less pronounced when she stands up, and especially with the weight of the prolapse, it does increase in size. So what are you doing first, Rachel?
I get the spray.
The adhesive spray. Is that my cue?
That's your cue. Thank you.
Do you need any cloths?
Yes, please. Thank you.
You tell me what you need. I'm your glamorous assistant. Yes, say yes.
Yes.
Thank you. Okay. Well done. Okay, now that isn't that's not the 8 inches that it can be. That's
No.
smaller. That's great. Okay. So, you clean round. Do you want some warm water? Or are we going to replace it first and then you clean?
Yeah.
So you want the ice now?
Yes, please. Yeah.
Okay. So the ice I'm going to put in a cloth. Do you normally put the ice directly on your stoma?
No, no.
No,
I
you
wrap
always
it.
use a
yeah,
cloth.
I always
Okay.
use cloth.
Excellent, because
I
that's
don't want it to freeze it.
yeah. No, you shouldn't put it directly onto the stoma. So here's some crushed up ice I prepared earlier. That's what they say on cookery shows, isn't it? Yeah.
What's odd is how it pulsates all the time. It's like moves, and that was what shocked me the most.
That's peristalsis. So that's the normal movement of your gut. You got that? The movement? Can you see it moving? Maybe. Can you see it on the screen?
Yeah.
Yeah, you got it? Marvelous.
You don't really see that with a normal stone. My urostomy is a dream. It's tiny and.
There you go.
Thank you.
There's ice.
Okay.
So you literally place it on top of the stoma.
Yeah, just try.
Oh, and you round it. Okay.
I try to get the swelling down because it's hard to push it in if it's very.
Yeah, I mean, that's the
thick.
right thing to do, to try and reduce the edema and the size of the prolapse before you manually reduce it. Although Rachel's going straight for the reduction here. This is the expert at work. This would take me at least 15 minutes before I'd be at this stage. Don't know about you, does it? It takes a long time, and I think we tend to be much more gentle and concerned about pushing it in. No pressure there, Rachel. Take your time. We've got plenty of time, so
I just put it over.
Yeah.
I find an ice pack wrapped in a towel easy for me, and I put that over the pouch before I take the pouch off to help get some of it.
So you do the icy bit first as well?
Yeah, I do the ice bit after as well, but...
Okay, so that's a top tip. So if a person has a prolapse, to actually put the ice pack on for a few minutes before you remove the pouch, and then do it afterwards as well. Ooh. Okay. So Rachel is very carefully with her fingertips, gently pushing the stoma back into place. How expert is that? I couldn't do it as good as that. I don't know about you, but that's an expert. Well, yeah, round of applause.
But it comes
And
out.
with hundreds of people watching as well. Way to go, Rachel. No, don't make her laugh. It's going to come out again.
No, it did come out.
Shall I put my elbow? Okay, so. I'll keep it in, keep it in. Right, what do we do next, Rachel?
I wipe round.
Right round. Warm water.
Warm water, yeah.
Warmish water.
Thank
There
you.
go. Brilliant. Gauze to dry.
Yep, thank you.
Now, you use a skin wipe. Do you want to use this?
Yes, yeah, I use it sometimes. I don't use it all the time. I do use it sometimes. That's the problem. Is it's
Yeah, it comes.
constantly-
Yeah, it's a devil, a little devil, and it's on film. Says I haven't been out long enough. I'm coming back.
Mr.
This is my
Prolapse.
one chance. I'm famous.
Come on, please go in.
It's fine. It's going in. I'm going to hold it. Drying thoroughly is important, isn't it? Really, to get the skin as dry as you possibly can. So shall I do a quick whiz round with?
Yes, please.
So these wipes you find help protect the skin, stop any irritation. We'll just leave that to dry for a second. Okay, just hold that like that. What should we talk about? Where are you going tomorrow?
We're going to.
You're going to Tivoli Gardens?
I think, yeah, we're going to try the coloured houses and maybe a beach.
Oh, a beach.
Possibly, yeah. Our flight got cancelled, so we're staying an extra day. So we're so sad.
Okay, now, because of the changing size in the base of your stoma, you can almost see now the skin margins are changing as we're watching. No. Oh, no. So Rachel cuts her product on a daily basis. She does not have a pre-cut hole because it changes. Now, Rachel, I've got scissors. I've got a pouch. You're the expert. You look at that and you cut the size,
Yeah.
or do you use a measuring guide?
What?
Do you do?
Yeah.
Fine.
Do you
Okay,
mind
no,
doing
you
it?
do it. Shall I do it for you?
Is that okay? Yeah.
Absolutely.
I normally try to do it before.
Yep.
Sorry.
Pop
It's
that.
hard to do it with gloves.
Yeah, no, absolutely. I'm with you on that.
It's hard to know how to cut it because it does change so dramatically, like even now. So I struggle sometimes. Some days it'll be smaller and other days, and I always worry that I'm not going to cut some off because sometimes I have had a prolapse that I've had to have emergency surgery because the blood had come off and it was like a purpley black colour.
So no pressure there for me getting the size. Yeah. Let's have a look. Okay. Let me just a little bit wider. Okay, so
Perfect.
we're the right diameter. So let me a little bit deep here. Yes. Okay. Phew. But before you put the pouch on, you use a seal. Okay. So shall we put that? We
Yes.
put that. You put the seal onto your skin, not around the
Yeah.
stoma. 'Cause some people find it easier to put the seal onto the adhesive. In general, not particularly with concave, but you.
I think because this changes shapes all the time, having the seal it's hard. If it's out and the seal gets stuck, so that's why.
Yeah. No, that's fine. Okay. And obviously, so you can see where Rachel has replaced the prolapse. The stoma, when she's lying, does go absolutely flush with the skin. Okay, which is why, in theory, we would say that she should use convexity. But we heard how a convex pouch didn't work. Do you want to do this, or shall I do this?
I can do it. Thank you.
It's difficult with gloves on, isn't it?
Yeah. Right.
Okay, I'll hold it in. If you want to take the base plate off,
Okay, so I flip it.
you do it how you do it, not how it
And
says on the
then-
packet.
I sometimes do.
Now, do we need to put? Do you push the stoma right back in, or do you allow it to spout a little bit?
I spout it a little bit because it's hard to do that with the ring.
Okay.
So probably that will do.
Okay, Rachel, I'm just.
Thank you. And then make sure fits in. Ooh. And I feel for the ridge, the circular ridge. Is that what it's called?
Yeah, so the stability ring is really a good guide for ostomists because actually you can feel it with your finger. So the adhesive, obviously, we're used to adhesive and heat bonding, but actually it's pressure that's going to fix this. So we need our ostomists, our users, to feel all the way around and put pressure on the stability ring, okay? And you do that first. Then you look at but look, immediately, I don't know if you can see with the pictures here, there are no creases. This is adhered with no creases over the bulge, okay? How do you like to, do you tuck the clip under as well, or
No, me and Steve have a little thing at home because he likes his in and I just like have mine out.
you like yours out?
Because I like simple.
Now, for many ostomists who have had a challenging journey, like Rachel, where she has had multiple leaks, okay? So we know what that does. We learnt this morning what that does to somebody's confidence, okay? So we, psychologically and practically, some people are very used and feel much more comfortable having flange extenders because that's what they've used in the past, and it's that extra security. Now, for concave, we have an large, an extra large flange extender. Okay, and Rachel likes to use these. Gives that added security, that ability to get out, go to the Tivoli Gardens, do whatever she's, out clubbing tonight, whatever.
Thank you. On that side, yeah. Okay. Voila.
Okay. And I don't know if you can see the seal through the pouch, the perfect seal there, and sizing around the stoma. So, Rachel, thank you. I think you're incredibly brave to do this. I'm going to clear the detritus and the mess that I have made. And you're going to do your trousers up. And then I'd just like you to stand.
Okay.
Or sit on the side of the bed so that we can immediately see what happens with regard to the prolapse and with the body shape, so that we can see that already, being on seconds, this is going to be supportive and secure when the stoma comes out. Okay, so already the prolapse is coming out. Can you see? Already it's an inch or so and it's coming out, and the contour is changing already of her abdomen. And you can imagine during the course of a day when Rachel's sitting, standing, lying, going swimming, the multiple changes that will happen in her body shape. And the difference that between the convex mio and new concave is the ability of the adhesive not only on the external area to stretch and go back, that we're used to in all mio adhesives, but this ability to almost be, I'm not very technical or chemical, I kind of see it as a shock absorber. So the adhesive sticks around the stoma within the stability zone, but is able to stretch and move up and down as the shape increases, while still remaining on the skin. And we learnt yesterday that it's this up and down movement that if the adhesives lift from around the stoma, and that's what causes the leakage. Thank you.
Oh, wait, no.
I don't know who's more relieved, Rachel or me. I think it's me. So, Rachel, let's sit back down again. Okay. So, how are you now? What difference has pinching Steve's product, but now appropriately using the correct size base plate and product for you? What? You've still got a prolapse. It doesn't cure your prolapse. No. You've still got a hernia. So what difference does it make?
It fits. It literally fits like a glove. It feels secure. Before, especially when you've got the prolapse and you've got a hernia, feels like it's just kind of resting. It doesn't feel like it's fitting. Like, I like the analogy yesterday where they said there's starfish grabbing a stone. Like, that's how it actually feels, and it feels like a glove. I can't leave it on as long as the convex, but it fits better. It gives me comfort. I know that I'm not going to have leaks. I don't need to wear a wrap. I wear supportive wear. I haven't got it today because it would be hard, but I wear supportive wear in a day to help. And I feel secure. I feel like I can go swimming. I can go abroad, you know. And I didn't do that before. For 6-7 years I've not been abroad. And
now you're here.
I know, and now I'm here. And I think it's definitely helped. It's made me feel more secure, and it's made me feel confident in the product that it's going to work.
Because actually you've had no leakages since you've been using this.
No.
It's almost like I wrote it, really, isn't it? But I didn't. I didn't. Rachel, I think it's phenomenal. I mean, you're very inspirational in the way that you do cope with a challenging situation, and you do cope with 2 stomas. So we only had half of the kind of what life is like at home for Rachel. But what I think is important is that this is a solution to you that officially, maybe if you read, but shouldn't be an option. We wouldn't normally offer as an option, but actually it works better than what we would consider the standard option for a telescoping stoma because of its ability to actually hold and stabilize the area around the prolapse. Rachel, I'm sure as stoma care nurses in our career, we come across a small number of people that have the kind of challenges that Rachel has, but you are not in the majority. It's not what we would see on a daily basis. What's your message to stoma care nurses in the audience now for the future when they next meet a person with a complex stoma prolapsing or telescoping that also has a hernia? What would you say to them?
I think it would be that they're not alone, because I did feel so alone, and I kept feeling really angry with my body because all the surgeries, I kept thinking, was it something I'd done? Did I lift something? And I kept questioning myself, and then it made me fear everything. And I think just like for them to know that they're not alone, like this does happen. It might not be common, but it does happen. And I think when I realized that, that helped me realize that actually it's not really a big thing, because I made it into a thing that stopped me from participating in life. And yes, it's difficult, it's troublesome, it's you know, the hernia doesn't cause me as much difficulty as the prolapse. The pain comes from the prolapse. But it doesn't have to stop me from doing things, from traveling up to see Steve, from all these opportunities. So I think it'd be to say that they're not alone and that there are other people that have it.
Okay. Well, I don't know if there are any burning questions in the audience. Anybody got a question they'd like to ask Rachel? I don't know if
you didn't tell me this bit, Terry.
No, I just made it up. I've just made it up. I just made it up. So to summarize, the key things, if you're looking in the future to being able to use concave, the thing that we suggest is that actually the first thing you do is measure the stoma, and you pick the product that is nearest to the cutting size that you need for the stoma. There are variations in sizes of base plates. Okay, but actually the first thing is to get the size right for the stoma and then look at, okay, well within the cutting size that you need, there may be 1 or 2 base plate concave shell sizes. We always say start off with the smaller size first, okay? And yeah, so just, I'm sure, on your behalf, to thank Rachel so much for sharing her expertise with us and how she deals with this on a daily basis. And to thank you all for participating and being here. So thank you.
Thank you. Thanks, Terry.